Hey, Doc. I'm back again, causing that chest pain when folks try to exert themselves.
Angina, you show up when the heart's not getting enough oxygen, but we've got ways to deal with you.
What's the plan this time, Doc?
Beta blockers. They slow the heart down, reducing oxygen demand. They're the first line of defense. And if you don't back off, interventional procedures like stents or bypass surgery to keep you under control.
Sounds like I've got a tough fight ahead. I'm not just any ordinary pain, I'm stable angina, the chronic kind that shows up when the heart's working hard.
I know you well, Angina. You appear when the heart isn't getting enough blood due to blocked arteries, usually from atherosclerosis.
Exactly. When someone's at rest, they might not even notice me. But when they start to exercise or stress, that's when I really make my presence known.
It's that mild ischemia causing your symptoms, and when it's due to coronary artery spasms, we call it Prinz metal angina. You can show up even at rest.
That's me, unpredictable as ever, but I hear you've got calcium channel blockers and nitrates to try and keep me in check.
That's right, Angina. Whatever it takes to keep you from causing too much trouble.
I may be stable angina, the chronic kind, but I'm no joke. I'm a warning sign that bigger problems might be coming.
You're right, Angina. You might show up predictably, but the risk factors you come with, like smoking, diabetes, high cholesterol, hypertension, stress, alcohol, age, and being male, are all serious.
And if I'm not managed well, I can lead to something worse, like a myocardial infarction or even death.
That's why it's crucial to control your symptoms and reduce all those risk factors. We can't afford to confuse you with more dangerous conditions like unstable angina or a heart attack.
The presentation of angina may vary between patients. However, most will report the main symptom of chest discomfort precipitated by exertion. Other symptoms include tight, dull, or heavy feeling of discomfort that is retrosternal or left-sided in nature, radiating to the left arm, neck, jaw, or back, breathlessness, relief of symptoms on rest. Other triggers may include cold weather, large meals, or emotional stress.
That's why it's important to recognize your signs early and take action to keep you under control. So, Doc, how do you really know it's me causing all that chest discomfort? I mean, there are other culprits out there.
You're right, Angina. Diagnosing you isn't straightforward because conditions like dyspepsia, severe anemia, pulmonary embolism, or even a heart attack can mimic your symptoms.
So, how do you catch me?
We start with a thorough clinical assessment, checking blood pressure, cholesterol, blood glucose, thyroid function, and hemoglobin levels. And an ECG is a must.
But that's just the beginning, isn't it?
Exactly. If we suspect it's you, we use exercise tolerance tests, stress echocardiography, or even myocardial perfusion scintigraphy. But the gold standard is coronary angiography. It shows us exactly where and how bad the blockages are.
Looks like you've got me cornered.
That's the idea, to make sure we know exactly what we're dealing with and treat it right.
The management of angina is threefold. First is to reduce the symptoms of the condition and also to prevent the angina from getting worse, and thirdly, lower the risk of severe cardiovascular events.
We focus on two things: reducing the heart's oxygen demand and improving the coronary blood supply. That's where drugs like beta blockers, calcium channel blockers, nitrates, nicorandil, and ivabradine come in.
But I have heard you also use aspirin. What's that for?
Aspirin is crucial for preventing cardiovascular events in patients with heart disease like you. It works by inhibiting cyclooxygenase, but we have to be careful. Other NSAIDs can compete with aspirin, so it should always be taken before any NSAIDs.
Beta blockers are the first line of treatment for angina. They slow down the heart rate, reduce the force of contraction, which gives the heart more time to get the oxygen it needs, and also decrease its demands.
I've heard about those, especially the cardioselective ones like atenolol and metoprolol. But what if someone has asthma?
Good point. Beta blockers can cause bronchoconstriction in people with reversible airway disease like asthma. So we have to be cautious. And if the beta blockers cannot do their job, or if someone cannot tolerate them, we have other agents that can be added or used as alternatives. But usually the beta blockers are our first line of defense.
treatment sounds like a careful balancing act.
Calcium channel blockers are great for managing angina. They cause vasodilation, which increases blood supply to the heart. Plus, rate-limiting ones like verapamil also reduce oxygen demand. Yes, verapamil should generally be avoided if a patient is already on beta blockers because it can increase the risk of a systole. But if they're not on beta blockers, it can be quite effective. If that's the case, we often add a dihydropyridine-type calcium channel blocker, like nifedipine or amlodipine. They don't have the same risks as verapamil and help manage your symptoms better.